Hello everyone. Let's have a look at the case of this week. A 70-year-old man presented with headache and vomiting. He underwent MRI, which revealed a presence of a solid cystic mass in the parasagittal region of the right frontal lobe, measuring 2.2 into 2 into 1.5 centimeters. So he underwent surgery, a linear incision was taken, and a small frontoparietal parasagittal craniotomy was done. The tumor was found intraaxial. It was gray, relatively vascular, and friable. What we received in lab was a very small amount of tissue, 0.5 into 0.4 into 0.2 centimeters. We processed that for histopathology, and what we found was sheets of undifferentiated cells which were infiltrating the brain parenchyma. These neoplastic cells were large, round to oval. They were in sheets, nests, at places pseudoglandular pattern you can see, and even at some places they were around the blood vessels, that is angiocentric pattern arrangement of the cells. Now these cells, they had a high NC ratio, and at some places they showed presence of prominent nucleoli. Nuclear pleomorphism, increased mitotic activity was noted, and even areas of necrosis were seen. So on the histopathology, we called it as a poorly differentiated malignant tumor. And what we had in mind, the differential diagnosis were lymphoma, poorly differentiated carcinoma, or a melanoma. Now, I thought of melanoma because it showed presence of central prominent nucleoli. So we did immunohistochemistry, which was very important in this case. The GFAP was negative, thus a glial tumor was ruled out. LCA was negative, lymphoma ruled out. Synaptophysin was negative, possibility of neuroendocrine tumor was ruled out. Cytokeratins were negative, so the carcinoma was ruled out. Now, what came positive was S100, so which indicated it could be a tumor of neurogenic origin or of a melanocytic origin. HMB45 was expressed, and so the diagnosis of melanoma was confirmed. At the same time, Ki67 proliferation index was very high. You can see it was 55 to 60%. So we gave it as a melanotic melanoma of the right frontal lobe tumor. Now the problem here was, since the melanin pigment was not present, we had to do immunohistochemistry. Now this patient was advised to undergo thorough clinical examination, look for some primary. He also was advised to undergo PET and USG. The brain tumor metastasis can be from carcinomas, which could be most common is adenocarcinoma from the lung, breast, colorectal, stomach, and renal cell carcinomas. It could be either lymphoma, usually those are diffuse large cell B cell type of lymphomas, melanomas, sarcomas, and germ cell tumors. Now, the melanocytic tumors of the CNS, they are diffuse or localized tumors that presumably arise from the leptomeningeal melanocytes. The types of melanocytic tumors are meningeal melanocytosis, meningeal melanomatosis, meningeal melanocytoma, and meningeal melanoma. Now, rarely these melanocytomas or primary melanomas, they do not demonstrate the melanin pigment, which makes the diagnosis difficult. So these, when we do immunohistochemistry, we call it amelanotic melanomas. And now when this pigment is not present, it is called detergent of the tumor cell. So what is important is immunohistochemistry becomes very mandatory in this case, in such cases. Now, these are very highly aggressive tumors. They are radio resistant and they have poor prognosis. They can metastasize to any remote organ. Thank you very much. I hope you all enjoyed this case.